Welcome to the July 9th, 2025 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, please take the roll.
Director Wallace.
Here.
Director Nicholson.
Present.
Director Yee.
Present.
Director Stewart.
Present.
Director Epen.
Present. 4 presents and 1 here. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record and proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Or are there any written communications?
There are no written communications.
Okay. We are going to move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? May I have a motion to approve the consent calendar, items A and B?
Mr. President, I move that the Board of Directors approve the consent calendar, items A and B.
Thank you. Sure.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye. Thank you. That motion is approved. And we're going to go into the presentation.
Yes, I'm going to turn it over to Terry Hunter to introduce our speaker, Jennifer Kubitz, our Director of the Trauma Program. But before I do, I just want to say that as a health system, we hit a large milestone operating as a trauma center for 1 year as of July 1st. And once again, I just really want to thank everyone in the health system. That becoming a trauma center and operating as a trauma center has touched everyone in this health system. And it couldn't have been done without everyone working together, having that collaboration, that strong communication. And it is a continued journey, and you'll hear that tonight, I think, by Jen. But I just really want to thank the physicians, the staff, everybody, whether you're in direct patient care, whether you're in finance, security, everyone has played a role in this success. And I know our community is very thankful for the journey that this system has been on and being able to ensure that we take care of all of the patients in this community, no matter how injured they are. So I will turn it over to Terry, but just wanted to say a huge thank you to everyone throughout the health system.
Yes, thank you, Kimberly, and thank you, Jen, for being here tonight. And it's my pleasure to introduce Jennifer, who many already know because of how involved she's been, especially in our outward presence in so many of our community settings. But Jen's worked in the medical field for the last 20 years. She started in the EMS for Alameda County. Prior to coming to Washington in 2024, she worked for 10 years at another Level 2 trauma center. During her tenure, she was heavily involved in their 2019 re-verification accomplishment. She went on to lead the Trauma Process Improvement Team and receive recognition as a national best practice in quality benchmarking, multidisciplinary loop closure, and trauma PI in a subsequent ACS survey. Jen has provided innovative leadership for numerous interdisciplinary process improvement projects and joined our Washington health team in April of 2024. We have been privileged to have Jennifer leading our trauma team in our journey to become ACS certified. Jennifer especially loves the aspect of community education and injury prevention. She can be found at the center of many of our community events and is always willing to lend her teaching talent. In addition, she has personally taught many of our staff education and trauma certification courses. Jen is a lifelong Bay Area resident and currently lives in San Jose with her husband and 2 boys, ages 12 and 4. They enjoy road trips and exploring different areas of the country. She loves serving and leading projects for the home and school club in her son's elementary school and is an advocate for children with special needs and epilepsy. Jen's passion for trauma and community is evident in the work that she does. Most of all, she's an example of putting patients first and committed to ensuring best care and outcomes for our injured patients. So with that, I would like to turn it over to you, Jennifer.
Well, thank you so much. I really appreciate the opportunity to come and share with you some of the really big successes we've had with our trauma program over this first year. And I just wanted to start by saying thank you to all of our distinguished board members and to our executive team and our CEO, Kimberly. It's just been an honor to serve this community with you and to build this program. And I'm really looking forward to what the next 10, 20, 30, 50 years looks like as a trauma center. It's been a really fun journey. So with that, if you could advance to the next slide, or you're able to see my slides?
No, I'm going to share it now.
Oh, perfect. Thank you so much. Perfect. And so I wanted to start off a little bit talking about the national structure around trauma. I'm sure you've all heard little bits of it throughout the journey to become a trauma center. You've been invested in this process for years before this first year of trauma. But as we really look at our trauma partners, first it starts with our local trauma partners, our LEMSA, which is our Alameda County group that really helps to back us and that designated us last year to be a level 2 trauma center. And they are supported by the state legislature as well as the national trauma folks at American College of Surgeons. And they also work with the National Trauma Database and our Trauma Quality Improvement Program. And so starting at the top, at the national structure, the American College of Surgeons really sets the bar for trauma across the country. They encourage national benchmarking through their data quality improvement programs. And that's done with the collaboration with the National Trauma Database, or NTDB. And they set a standard of trauma audit codes and filters that we look through all of our patients' charts for. And that will help us to get our benchmarking as we move forward into trauma. We report that data every quarter to NTDB and ACS. And we will be very soon getting some reports that allow us to see how we look as compared to other trauma centers across the country. And so because we're comparing the data that we have been collecting here at Washington with other trauma centers across the country, there's various numbers that we use when we talk about trauma. And so our tracking of injured patients can sometimes be a little complex. We like to look at the total number of injured patients as required by NTDB, ACS, and TQIP. And so that means that's going to be a larger number than our trauma activations, which is a smaller subset. And so when we're looking at those, the national bodies, ACS and our LEMSAs, they really help to define the criteria by which we activate trauma patients. And that criteria changes over time as newer evidence-based practice comes out. So for example, if you look at the car that you likely drive now, it looks very different than it did in the 70s. There's a lot of different seat belts, different airbags, and different sensor systems that happen. And so one of the really big recent changes that was made to the trauma activation criteria at a national level is they removed the factor of speed. And so it used to be that if you were in an accident over 40 miles an hour, you would be trauma activation. And now they look at patient compartment intrusion. And so those things are really looked at through evidence-based practice. And that ties back into the data that we and all of the other trauma centers across the country supply to NTDB. They're able to pull all of that data forward. And so as we're embarking into trauma and submitting our data, we are also a part of those national benchmarks and how we look at who is injured and who isn't. But so speaking about our trauma registry, that will be the total number of patients that we have in our registry. And those are all patients that meet the inclusion criteria set forth by ACS and the National Trauma Database. Next slide, please. So that number for us this year in our first year was 2,308 patients that are in our registry. So I think that number is a little bigger than some of us were expecting to see. But it's also really interesting to look at where those patients come from. 97% of those patients came from the communities that surround our hospital. And so that really supports the need for having a trauma center located here in Fremont. In Fremont alone, we had over 1,200, almost 1,300 patients come to us because of injuries that they sustained needing trauma care. And so as we move forward, those numbers will only continue to grow. As we look at the types of injuries we have, you'll see at the next slide, please. You'll see that the largest group of our trauma patients is falls. And that shouldn't be surprising to anybody. That's a trend we're seeing across the country. As our population changes, falls is becoming more predominantly a part of our trauma community, especially with geriatrics. That adds a lot of comorbidities and reasons for having trauma programs, evidence-based practice, and multidisciplinary guidelines to really support the processes that ACS expects across the nation for trauma care. And so looking at our top 5 mechanisms of injury, these are our trauma activations. So this is our Alpha, Bravo, and Delta categories. And we classify those categories in a way to allow us to look at how severely injured the patient is and what resources they're going to need when they come into our emergency department. So for example, somebody who's a polytrauma patient who has multiple injuries and has low blood pressure is going to need a lot more resources than somebody who fell, hit their head, but is able to ambulate and is alert and oriented. And so those higher level activations are alpha traumas. They bring more resources to those patients in our emergency department. And when we look at the top 5 mechanisms of injury, you can see, like I mentioned, falls is around 60 to 65% of our trauma population. Then comes MVC, and then the rest of the injuries are sort of similar in numbers. Those top 3 are motorcycle collisions, pedestrians, and bicycles. Looking at the top 5 mechanisms of injuries allows us to look at what we can do in our community to prevent these injuries. As a trauma center, our goal is to prevent injuries and to train people in the community about how to be safe when they're out and about in our community. Next slide, please. So I know that number of falls is a pretty big number, 1,208 patients broken down into a lot of subcategories. And a question we often get is, what kind of falls? So it's not all from a ladder or a roof or a tree, although around the holidays, we'll probably see more of those patients that come in. But most of these patients are ground level falls. And the next largest category is falls due to slipping, tripping, or stumbling. And so this allows us to really work in the community about mobility, making sure that our community stays active, making sure that they're able to stay flexible. Those all really help to prevent falls, and also giving safety tips. And we do that in our Matter of Balance and Bingo Size fall prevention classes. If you're ever around on a Monday or a Wednesday, come on by the Anderson Auditorium. We do Bingo Size, and it's fun. We have about 30 people in each of our classes who are learning about different types of fall prevention and movement that really helps to get them into the community and integrated into those classes. Next slide. So talking about injury prevention, this is a pretty big number, and since June of last year, we've touched almost 3,000 people with injury prevention. And that's all in our community for choking, stop the bleed, teaching tourniquet use, and fall prevention. Distracted driving and programs like Every 15 Minutes, which really support drunk driving and prevention of that type of an injury out in the high school population, is something we're really excited to bring to our community next year. We just look to grow that number and really be invested in providing services to prevent those top 5 mechanisms of injury. Next slide. As both Kimberly and Terry mentioned, this journey in trauma would not have been possible without the support of literally every service at our facility. There's over 42 disciplines and departments in our facility that participate in trauma care, all the way from our EVS and our supply chain to our frontline services, our physicians, our phlebotomists, and as Kimberly mentioned, really every area in the hospital has really helped out to make this a success. I'd like to draw your attention to the fact that we had over 80 educational classes in the first year. And that was really done to support the frontline staff and make sure that we were ready to take on trauma. And I think we can all agree, looking at the patient outcomes and seeing some of the really amazing stories that are coming out from our first year, that we've excelled in a lot of areas in trauma. There's a lot of work left to do, but this first year has really given us a step up in the right direction. And I know that with the continued support, we're just going to continue to get better and better and see those service lines expand, see the physician specialties get more engaged, and really see the staff start to develop unit champions and get further invested in trauma. Next slide. And so once again, I just wanted to say thank you for all the support that you've given in our first year and before. And we as a team in trauma are really excited to continue the journey with you. So thank you so much for your time, and I'll take any questions that you have.
Thank you, Jennifer. Any questions for Jennifer? Okay, well, everything is going great. Keep it up. Let's go.
Thank you. Thank you, Jen.
Okay, yeah, I'm going to move on to the reports with
Yes.
Dr. Berry.
Yeah, Dr. Berry is now our chief of staff, and so he will be giving the report this evening. So welcome, Dr. Berry, for your first meeting as chief of staff here.
Hi, good evening. It's a pleasure and an honor. So this is my first time at this meeting. Dr. Saleh gave me a heads up of what he usually presented, but if I'm lacking in anything or you'd like to hear a little bit more, certainly let me know. But as far as an overview of the medical staff, we have a total of 675 people on the medical staff. Of those, 374 are active members, 99 are ambulatory, 8 are consulting, 13 courtesy. We have 75 who are provisional active. We have 39 advanced providers who are active and 8 provisional advanced providers. And we also have 54 provisional consulting members, and currently 1 person with temporary privileges. The rest of the breakdown by department is in the agenda that you should have in front of you. We have several new members of the medical staff. There's Matthew Golubjatnikov, who is an emergency medicine physician. We have Mandar Vishwas Joshi, who's a teleradiologist with specialty teleradiology. We have Jake Lee, who's a podiatrist. Holly Martin, who's a peds hospitalist. And Rambabu Thalapaneni, who's a family medicine practitioner. In addition, we have 4 teleradiologists from StatRad joining the medical staff: Daniel Ball, Anthony Galanado, Sunil Gujarati, and Hasti Larjani. We also have an additional teleradiologist with StatRad on the next page named Damian Duncan. Those are the new people joining staff. A couple other general announcements. The dinner dance honoring Dr. Desmond Erasmus was on June 28th. I know a few board members and Kimberly were there. It was a very well-attended event, and I think everyone had a good time. And we are continuing to work through the process of updating our ID badges. Everyone has or should have submitted a new photo that will be printed with the new badges, and we expect those to be delivered, I believe, the 21st, or at least that week. It's coming up in the next couple weeks. And then the last and final item is we are recreating officially the Peripheral Vascular Committee. Dr. Jeff Thomas and Tim Choi have agreed to help rebuild that committee, and we will expect recommendations from them shortly. That concludes my report. Any questions?
Okay. Any questions, anyone?
Thank you.
All right, Dr. Berry, it's good to see you, and you're not driving or anything. It's just safe
I,
and sound in your office.
clearly not. I hope you all
Thank
have
you
a great
very much.
evening.
Thank you.
Thank you.
Okay, Sheila.
Sheila, DJ is next.
Good evening, members of the district board. I was not here at the last meeting and the chief of medical staff changed. I don't know what happened. Anyway, I extend warm greetings to all of you. In June of 2025, 271 Service League volunteers contributed 2,504 hours of service across various hospital departments. To begin this report, I'd like to share a brief update on the No One Dies Alone, NODA for short, program. Since its launch in August 2023, volunteers have kept vigil for approximately 35 patients, averaging about 1 and 2 vigils per month. The program continues to provide support for patients who might otherwise be alone during their final moments. As part of this month's report, I'd also like to highlight Sahil Patel, one of our nurse unit assist trainers and a longtime volunteer. Sahil has been with the Service League since 2019 and has recently applied to medical school. I had the opportunity to write a recommendation in support of his application. Sahil's reflection offers insight into his journey and motivation. He says, I spent much of my childhood in my grandparents' care, where I developed a close connection to nature through gardening. As a shy, introverted child, I struggled to connect with others, but found comfort in nurturing plants. When my grandparents began facing the challenges of aging and illness, I saw clear parallels between tending a garden and caring for people. That realization led me to join the Washington Health Service League in 2019. Over the years, volunteering helped me grow. I listened to patients, supported families, and worked closely with staff. In time, I developed emotional intelligence and an understanding of how people react in difficult situations. As a volunteer trainer, I guided new volunteers to notice subtle signs of discomfort, respond with empathy, and understand the value of being present at the bedside. While community work broadened my understanding of health, it was in the hospital where my commitment to medicine deepened. I saw how a small gesture, a conversation, or simply listening could ease suffering and build trust. These years of experience have shaped my desire to pursue an MD to support patients and help them through challenging times. Sahil's story shows how our program impacts not only just our patients, but also the volunteers who serve them and how it changes them and they apply to medical school. So I was very impressed with this young man, and I just want to wish him all the very best. That's the end of my report. Let me know if you have any questions.
Well, thank you. That was a beautiful letter there.
Thank you. Thank you, Mr. Wallace.
Questions, anyone? All right, well, thank you, Sheila. Thank you.
Thank you.
Thank you.
Thank you.
Okay, that's all of you.
All right, next we have the quality report, and the topic is our stroke program. And here this evening to present is Dr. Jack Rose, our co-medical director of the stroke program, and I'll do a short introduction of Dr. Rose. He joined Washington Health and Medical Group in early 2014. He received his undergraduate degree from Stanford University and his medical degree from Columbia University School of Physicians and Surgeons. Dr. Rose received his medical and neurological training at New York Presbyterian Hospital's Neurological Institute, where he was selected as chief resident. He did a 2-year neurocritical care and stroke fellowship at the University of California, San Francisco. Dr. Rose is an expert in neurointensive care and cerebral vascular disease and was among the first 100 physicians in the world to become board certified in neurocritical care. He's board certified in neurology and also as well in vascular neurology. Dr. Rose's experience and leadership augments our comprehensive stroke and neurosurgical programs, especially in cerebral vascular neurosurgery and interventional neuroradiology. He personally provides the patients treated at Washington Hospital with a continuity of care that is critical when treating the full range of cerebral vascular conditions. Dr. Rose is co-medical director of the stroke program with Dr. Kalstep. He is also chair of the Washington Hospital's Continuing Medical Education Committee and the Institutional Review Board. So, welcome, Dr. Rose. I will turn it over to you. I think are you gonna, we'll share the slide.
Okay, thank you very much. Kimberly, can you guys hear me all right?
Yes.
Yes.
Okay, excellent. It's an honor and a privilege to again give you all an update on our stroke program. So thanks to the entire board of directors and Kimberly for inviting me to again share how our program is doing over the last year. And I'm pleased to say we think that we've done an outstanding job and are very proud of our entire team. And we'll go on to the next slide. Next slide. Since I last presented to you all last year, we have had a little bit of change in terms of our leadership structure, but Terry Hunter has been on the top of our nursing administration, and Mary Barron, who many of you must all know already, has also shifted from quality to also helping oversee our stroke program. And so we very much thank them for their assistance and leadership. Dr. Carlson and I remain the co-medical directors. Since I last presented to you, one of our prior neurologists no longer is taking our call or working in the hospital, Dr. Sharon Singh. And so we wish her well in her outpatient and semi-retired practice. But we've welcomed another stroke neurologist, neurointensivist, Dr. Walia. So we have 3 program neurologists in our stroke program. Myself, Dr. Khalsa, and Dr. Walia. And all of us, in addition to being board certified neurologists, we all have certification or extra training in neuro ICU care. So we're proud of that. We also have 3 outstanding interventional surgeons who now provide 365 24/7 care for patients that require the operating room or our neurocath lab for advanced neurosurgical endovascular procedures. So Dr. Jeffrey Thomas, Dr. David Carrington, and our newest interventionalist, Dr. Dan Raper, who also works at UCSF. So we're thrilled to have a full cadre of endovascular specialists. And since we have all 3 of them, I'm proud to report we haven't had to transfer any of our stroke patients outside of our hospital in a long time. And of course, we couldn't do the outstanding job that we do without Maria Nunes, who's now the director of our quality and special programs, not just the stroke program. And Charlene Singer has moved from her former role as a stroke nurse to now our neuroscience program coordinator. So we have outstanding nurses as part of our leadership team and day-to-day activities and quality reporting. We really appreciate all of this help in terms of our leadership. Next slide. The structure of our stroke program hasn't changed. We obviously have our patient in the center of the focus of our care, and it is a very multidisciplinary program, starting from EMS to the providers in the ER, both from the physician, nurses, and allied health people in the emergency room. We work very closely with our radiology department, our radiologists, our techs, our pharmacists, our pharmacy techs, our lab. We involve the neurologists, neurointensivists, intensivists, radiologists, and we have dedicated areas in our hospital where we take our stroke patients, both in the critical care units, in intermediate care, on the floors, and our cath lab. And we have outstanding rehab specialists in terms of physical therapy, occupational therapy, speech therapy, and we have very good support from our case management and social workers to help move our patients through their phases of care. And we focus on rapid, accurate diagnosis of stroke, rapid treatment, and aggressive, appropriate care to focus on getting the best outcomes for our patients. It truly is a sort of a patient-first centered program. Next slide. And since 2016, we're almost at the 10-year mark of our Code Neuro overhead paging system. Many of you that may be walking around the hospital occasionally will hear a Code Neuro called overhead by the operator. And that's just to signify that we have a patient in our hospital Oftentimes it's in the emergency room, but it could be anywhere in the hospital that are having signs or symptoms of an acute stroke within the last 24 hours. And we call that code overhead to rapidly get them to medical evaluation, rapidly get their labs drawn, they're taken to the CT scanner, have the ER doc and the ER nurse at their bedside and evaluating them, and so that we can rapidly diagnose their illness and get them the appropriate treatment very, very quickly and appropriately. Because time and time again, it's been shown that the faster you diagnose somebody with a stroke and the faster you get them treatment, the better chances for them having a better functional outcome is. And since 2016, we've been proud of this system to really rapidly move our patients through the early phases of their diagnosis and care. Next slide, and we'll show you some of our quality outcomes about that. Since I did last present to you last year, we've added a second overhead paging system. We call it Code Stroke MT. MT stands for mechanical thrombectomy. That's a term used for treatment of a stroke patient that has a blockage of one of their large arteries in their neck, or more often their brain, where we don't just give them medicines, but we actually take them to the neurocath lab, and one of our interventionalists does a procedure putting a device through their arterial system, through a small incision in their leg or their arm, and take that catheter all the way up to the neck or the brain artery that's blocked, and put a device in there to suck out the clot or to grab it with a stent and mechanically take that clot out. Mechanical thrombectomy. And this has been a revolutionary advance in stroke care, that if you get patients that have this severe type of a stroke to the neurocath lab quickly and take out their clot as fast as you can, the better their outcomes will be. And we've been trying to improve how rapidly we can provide this service to our patients. And one of the ways we figured that we would improve the time from the time that they come to our attention to the time they're in the cath lab getting their procedure is to use a code stroke type system, code neuro-like type system again, to rapidly say, hey, this stroke patient needs to go to the neurocath lab ASAP, and how can we optimize and speed up their care? And so this is sort of the chart of the timeline, how this process happens. If someone is identified as a candidate for this, the neurointerventionalist that is going to do the procedure will have the operator call this code stroke MT, and it rapidly alerts the cath lab, the anesthesia team, everybody involved in the cath lab procedure to rapidly get the patient there and to the procedure as soon as possible. And we've been seeing some very good improvements in our door to cath lab procedure device deployment. In fact, the last couple of cases we've met less than 90-minute target goal to getting the device inside the patient's blocked artery. So we're happy that we're seeing good results with this new overhead paging system, and we look forward to using it more and more in the future. Next slide. How has our patient volume been over the last year? Well, this is a chart going way back to the beginning of our Joint Commission Certified Stroke Program back in 2008. You can see that very early on in the early 2000s, we had around 500 stroke patients a year, but with the advent of other stroke hospitals in the Bay Area, that came down to about 450 to about 500 level. And that's been fairly steady up until about 2022. And interestingly, like I said last year, we never saw a dip in our stroke volume with COVID, but we have seen a slight decrease in our overall stroke patient volume in the last couple of years. And that's mostly because Tri-Valley, Stanford Valley Care opened up in Pleasanton. And so some of the patients that used to come to us from that area now go to that hospital because that has become the closer stroke center. It's not that we're having patients not sent to us for other reasons. And so we're hanging around that 400 annual stroke volume per year. And that both includes the bleeding strokes and the blocked artery stroke patients. Next slide. In terms of the type of the stroke patients we're seeing in the last 2 years, the blue are 2023 and the green are 2022, you see that blocked artery strokes, those are called ischemic strokes. It's about 60% of our patients. TIAs, which are warning signs of a stroke, are about 15 to 20%. Subarachnoid hemorrhages, which are usually bleeding strokes into the fluid spaces in the head caused by ruptured brain aneurysms, that's about 6 to 7% of our patients. Many of those patients do come from outside, but we do get a few from our own emergency department. And then the rest are about 15% intracerebral hemorrhage bleeding strokes into the brain tissue itself. And so that has remained about similar the last couple of years. Next slide. In terms of giving TPA, which is a clot dissolving medicine, which is the hallmark of acute stroke care for blocked artery strokes, we try to give as many people that qualify for that medicine as possible, but our time window for doing so is very short. You have to give it within 4.5 hours since the stroke onset was known or the patient was last seen normal. And many of our stroke patients say wake up with their deficits, and it's been potentially longer than 4.5 hours. But we do an outstanding job of still giving TPA or this thrombolytic therapy to over 15% of our patients over the last 3 years. So if you look at the total number of blocked artery strokes, about 240 patients, we've given this thrombolytic therapy TPA about 40 cases a year. So it's almost one patient or almost one patient a week. And some days we have more than one. And we also are proud that in the last year, if you look at that fourth column there where it says endovascular therapies, that's the mechanical thrombectomy cases. You see that in the last 3 years, this past year in 2024, we've significantly increased the number of mechanical thrombectomies that we've done for stroke. We went up from 6 to 16 within 1 year. And so we're very proud of that. Next slide. In terms of other procedural volumes, comparing us in the last several years, you see 2019 all the way to 2024. Thrombectomies, those are the procedure I talked to you about before, this mechanical thrombectomy. Like I said, we went up to 16, which we're very proud of in the last year, compared to 6 the year before. In terms of clipping or coiling, that's a vascular neurosurgical procedure for aneurysms that Dr. Thomas and Dr. Raper specialize in. And we have a steady volume between 10 and 15 cases per year for that. We don't do very many carotid stents anymore because the literature does not suggest that that's better than carotid endarterectomies, and we have a good volume of that. This past year, we did 21 of those. Our vascular surgeons did that procedure, and we can do a less invasive procedure called TCAR if we want to, rather than a carotid endarterectomy. So we did one of those last year. Next slide. How have our outcomes been for our stroke patients? Well, one of the quality measures that we look at are the key performance measures identified by American Heart Association's Get With The Guidelines program, and they give us a number of quality metrics that we have to follow on all of our stroke patients. And in terms of ischemic stroke, these are the 10 most important ones that are followed. And the goal here is to be above 85% in meeting these metrics. And some of those include giving the education to the patient that had a stroke and or their families, giving patients the thrombolytic therapy quickly if indicated, preventing them from developing clots in their legs when they're sick in the hospital, giving them a blood thinner medicine early, making sure that's continued on discharge, counseling them about stopping smoking, giving them a cholesterol-lowering medicine called a statin, giving them a blood thinner medicine, of a particular type if they happen to have atrial fibrillation, assessing them for swallowing trouble, assessing them for rehabilitation and rehab, and then measuring their stroke scale score within 6 hours of admission. And you can see that we're at high 90s to 100% in all these measures from the last calendar year. So we follow this in real time and report at our monthly stroke review committee, and then yearly as well at presentations like this. So we continue to do an outstanding job with these metrics. Next slide. In terms of getting our patients rapidly diagnosed and given the TPA medicine if they qualify, we've had a really, really good improvement over the last 4 years since we changed our TPA from one particular type to a different one in mid-2022. And so you can see that the blue is 2021, green 2022, second blue is 2023, and all the way on the right is 2024. And you see that we've decreased the median time to get from the patient hitting our door in the emergency room to giving them TPA has gone down from about 50 median to about 30 minutes, which is really outstanding. And so we're happy that we've continued to improve that. And like I'll mention a little bit later, over this last year, we've had a significant change in the structure of our stroke program, whereas we no longer have dedicated separate stroke nurses. And so we wanted to make sure that with that change, we did not lose any of our outstanding gains in our rapidity of TPA administration. And so far, and since the last year that that's happened, we have not seen any decrease in our door to needle time, which we're really proud of. Next slide. This is just a breakdown of how fast we can give that TPA within the 30-minute time window, 45-minute window, or 60 minutes or more. From September of 24, when we restructured our program from having dedicated stroke nurses 24/7 to having just the bedside nurse in the ERB, the stroke nurse. And you can see that the two, and then so on the left is from the end of 2024, and the right column is from 2025, the various months. And you see that our breakdowns are very, very similar. And so our restructuring of our stroke program has not significantly changed how fast we're able to give TPA to our stroke patients, which we're very happy to report. Next slide. In terms of one of the main risks of giving that medicine, there can be brain bleeding as a complication of that medicine. We work very hard to try to minimize that risk. And this is a chart showing you from 2018 all the way to 2024, how many total strokes we've had, how many TPA patients we've given, how many thrombectomies we've done, and how many patients have unfortunately had a significant bleeding in the brain after either the drug delivery and or having a thrombectomy case. And you see that early on in 2018 to 2019, we had a small percentage, about 3% of our patients had symptomatic intracerebral hemorrhages. But once we switched to the new medicine, which is associated with less brain bleeding, we didn't have any. This past year, we did have an uptick in some of our brain hemorrhages, but that is directly related to doing more of these mechanical thrombectomies, which is a known risk of when you add that surgical treatment to medical therapies, does slightly increase the risk of brain hemorrhage, but the overall benefit remains for the best functional outcomes for our patients. So we're not concerned about that increase in number. It's just part and parcel with doing more of these embolectomy procedures. So we continue to track that going forward. Next slide. How were our functional outcomes at discharge in terms of our stroke patients compared to other hospitals that are in the Get With the Guidelines reporting? Well, at discharge, 63% of our patients are categorized as a fair outcome. Here it says good, but it should actually say a fair outcome. That's patients that are able to independently ambulate. As if you compare that with other hospital functional outcomes at discharge, it's only about 28%. So part of that is our unique patient population, but also I think it speaks to the high quality of our stroke program, our high quality of giving patients the optimal therapy and early rehabilitation. And we're happy that our functional outcomes have remained very high at discharge. And I'll show you some of our disposition data in the next few slides. Next slide. In terms of our mortality, how are our stroke patients doing in terms of risk of dying? Well, the chart on the left is going back from 2018 all the way to 2024, this past year. Washington Hospital is the blue bar there, and you can follow that along. You see that we've been around 4.5% to about 5% fairly steadily over the last few years, and that's comparing to the orange bar. That's the statewide mortality, and this is risk adjusted for measures associated with stroke mortality. And you see that we're very, very similar to the statewide stroke mortality rate. So we're happy to see that. There's no significant difference from 2024 with us compared to other stroke reporting hospitals. And when you look at a little bit more breakdown about some of our mortalities, you see the similar numbers all the way on the right where it says ischemic stroke with NIH stroke scale score in blue. 2023 to 2024, you see we're at 4.6 to 5.1, which is similar to the 4% rates that you see with other hospitals statewide. The left column where it says hemorrhagic stroke and ischemic stroke, we're slightly above, but not statistically significantly different than other statewide hospitals when you take bleeding and blocked artery strokes together on the last couple of years. And part of the reason we think that we're slightly above average is because we do accept a large number of, or at least a fair number of very, very sick brain hemorrhage patients from other hospitals that need brain surgery, and or sometimes they get to us in such dire strait we're not able to save them. But so we track our mortality data very closely and are very happy still with our stroke mortalities going forward, and follow this on a continual basis every month and then quarterly and yearly. Next slide. In terms of where our stroke patients go once they leave our hospital, where do they go? And for the past 3 years, we'd have similar numbers of patients going home, maybe from about 60% down to 50% in the last 3 years. Small uptick in patients going to skilled nursing facilities, but still only about 20% of our patients. We're seeing an uptick in our patients that go to acute rehab, which is great. A very small care. A few leave AMA, a few sadly will expire before they're discharged or at discharge, and some go to home hospice or hospice care at another facility. These numbers are fairly similar over the last 3 years. Next slide. In terms of performance improvement in our program, we continue to try to improve the percentage of patients get rapidly treated with TPA. This is just a slide showing you over the last 4 years how well we can give this TPA medicine within 60 minutes and compared to other certified stroke centers. We're in green, other stroke centers are red. You see that we've outperformed the other stroke centers in the last 4 years and continue to do so this past year. 96% within an hour versus 87% other hospitals. Next slide. Within 45 minutes, we continue to significantly outperform other hospitals. We've given 95% of our TPA patients within 45 minutes compared to 65% of other hospitals. Next slide. In terms of our door to CT metrics, we try to rapidly get our stroke patients to our CT scan because that's the only test that can tell us if there's a bleeding stroke versus a non-bleeding stroke. And you see over the last 4 years, we continue to get our patients to the CT scan within 25 minutes of arrival, a bit better than other hospitals, 61% versus 52% the last year. Getting that CT scan officially read by a radiologist. We're improving. Part of the reason we dipped down a little bit was because we've had a shortage of radiologists, and we've been trying out different teleradiology services, and a couple of the ones we initially switched to in the last couple of years underperformed for us, and we've fortunately found 2 new groups that do a much better job. And so when we dipped down to 72% in 2023, we've steadily saw that improve, and we're very happy now with our 2 new teleradiology services. And so those numbers you'll see, I imagine when I'm presenting to you guys next year, you'll see us at the level of other hospitals, if not better, going forward. Next slide. In terms of, this is just similar measures showing you that we've already made some improvements with this new teleradiology group called StatRad that have started with us in September 2024. So only several months, and you can see that some data already showing you, this is some quarterly data from 2023 compared to 2024, showing you that now we've gotten similar to other hospitals in getting our scans officially read within 45 minutes, almost 90% of the time this past quarter of the last quarter of 2024. So with our new StatRad teleradiology service, we've improved that measure that we noticed dipping down earlier in the year. Next slide. And then ED assessment within 15 minutes. We've continued to have that very high, better than other hospitals on average, and getting a rapid blood glucose level checked, again, better than other hospitals. Next slide. And then this is a performance measure that I mentioned early on. We're trying to speed up the time it takes for us to have if they need a thrombectomy. And this is the door to device time over the last 3 years. You notice that in 2021, our average time in minutes was almost 250 minutes. And we've gotten that, we shaved off a significant amount of time this past year to about 150. So 100 minutes shaved off. And if you follow this down in 2025, we're getting close to that dotted dash red line, which is 90 minutes. That's our goal. And like I said, the last couple of cases we've had, we've made that 90-minute time frame. So we continue to work hard to improve our door-to-device time. And with our new Code Stroke MT overhead paging system, we think it will continue to help us improve this quality measure. Next slide. In terms of giving statins on therapy, which we in 2019 identified as a suboptimal result, 56%, We made sure that we did as much as we could to make sure that patients were getting the appropriate statin at discharge. And since 2020 and steadily through 2024, we've been in the very high 90%. So this is a performance improvement plan that we're sunsetting because we do such a great job at it. We continue to monitor it, but we don't have it as a particular performance improvement project anymore. Just shows the sign of our success, and we continue to monitor it. Next slide. We're also proud that one of our goals is to have more patients show up via 911. Stroke is a medical emergency, and it's much better for patients or their families to call and arrive to our hospital system via 911 rather than private vehicle or walk-in. We used to, if you look back in 2018 on the left side of the graph, you used to see that the yellow bar were the EMS presentations and the green are the walk-ins and the dark green are transfers. You saw that before COVID, 2018, 2019, 50 to 60% of our stroke patients came in via EMS, but especially with COVID, that dipped down. People were afraid to call 911 as much, and so it balanced more 50-50. But we've focused a lot on community education to explain why a stroke is a medical emergency and you really should call 911 even if the symptoms went away, and to really use 911 service, EMS, to bring the patient to our hospital. And we're proud to report that in this past year, we've gotten closer to that 60% of EMS activation and transfer our stroke or potential stroke patients to our ER, only decreasing our walk-ins to about 40%. So we continue our educational efforts to continue to have this going forward. Next slide. Patient satisfaction, we follow up on how well our patients do, both at 7 days and at 90 days. We have a really outstanding service that we contract with that call the patients and have a very high yield of getting follow-up from our patients about how well they're doing. And we've analyzed this outcomes data every month at our stroke review committee. We created a discharge flyer to make sure that the patients know to follow up with their medical provider soon after discharge, and that they will be getting a call about their satisfaction and ask them some survey questions. Next slide. This is an example of some of the data we get back from this MedTel program, showing you some of the reports that we get for a large number of our patients. This one is showing you 20 patients that are followed up. And one of the things we noticed was that not a high percentage a few years ago of our patients were following up with their primary care physician within a week of hospital discharge, and we really wanted to improve that. And so we worked hard to make sure that the patients know it's important to have follow-up with their primary care doctor within a week or have an appointment to do so within a week. And so one of the things that we found by putting this into our discharge planning and education for our patients, we noticed a significant improvement from like 50 to 60% to sometimes some months over 90%. We've had a little bit of a dip recently about that, but we continue to track that and do everything we can to improve that. So, well, this is a continued performance improvement plan that's active right now. Next slide. In terms of education, we do a lot of staff education. I give a monthly neurovascular case studies. In fact, I gave one earlier this afternoon where we discuss 3 interesting stroke cases every month and go over the latest of stroke diagnosis and treatment and outcomes. We also have a neuroscience symposium that we give a lot of stroke talks. I gave a stroke talk this last symposium on our new TPA medicine that we give these days. We have critical care skills day for neuro. We do education for our ED and ICU nurses. We have code neuro simulation exercises. And then we focus a lot on patient and family education as well. One-on-one education with the nurses, with Charlene as our program coordinator, and talk to them about rehab and diabetes care, and the pharmacists are involved to make sure they understand what medicines they're being discharged on, and making sure the meds are appropriately understood, and then individualize the plan for each of our patients. Next slide. And then community education, we also do a lot of community education. We have a quarterly stroke education series. We do some concert in the park talks, Facebook Live presentations. We had a stroke awareness in the Tri-City newspaper. We have talks on endovascular therapies by Dr. Raper. We had a brain health talk by Dr. Walia. We have a stroke support group for survivors of stroke and or their families. which had been on Zoom since COVID, and we plan to start that in person this year. We also work with our EMS providers to attend quarterly meetings and give them education as well. Next slide. One of the things that we noticed in our community assessment from 2023 and then in 2025 is that there are some disparities in stroke visits in our communities. So, for example, when we looked at the 2023 data, that's listed as 2018 to 2020, that second bar there, we noticed that in Union City, this is stroke visits per 100,000 patients. So you see that the Union City number was about 69 per 100,000 patient, but in Newark it was only 54, and in Fremont it was 45, and then at the right, in Alameda County, the visits were only 56. So we noticed more stroke patients coming from Union City. And so when we saw that, we made sure to give a particular educational program in Union City. This was done earlier this year. We had a health walk event where we talked about the signs and symptoms of the stroke, and we had a health walk. And so we're happy to report that in the Newark Community Needs Assessment in 2025, Union City numbers went up, but not as much as Newark. So we've identified now Newark as an even higher rate of our stroke patients coming to us. And so now we want to focus some of our educational and other health events towards Newark. Because our Fremont population are a little bit better than Newark compared to the Alameda County average. So Alameda, now Union City is more like the rest of Alameda County. Fremont's a little bit better, but Newark has become our hotspot for trying to outreach and improve their health as it relates to stroke. Next slide. And similarly with stroke mortality, we noticed that like the incidence of stroke going up in our Newark patients, we've also noticed increase in the risk of mortality for our Newark stroke patients coming to us from Newark. So we're going to focus a bunch of our outreach and education and partnership with our Newark providers to hopefully improve this concerning trend. Next slide. Performance achievements. Next slide. We've received a number of awards from the American Stroke and Heart Association, Gold Plus Elite, and Target Honor Roll for diabetes. We've achieved the really rapid and maintained TPA administration times, like I showed you. We've adjusted well to our stroke restructuring program in terms of our stroke workflow, and we temporarily had a little bit of misses in terms of swallowing screening with the new stroke nurses change, but that has now gone back to our outstanding results. We're expanding our outreach for getting stroke patients from outside our community. We partnered newly with San Joaquin Valley. We had a meeting today with Watsonville Emergency Department, and we continue to have a good relationship with Santa Rosa Memorial Emergency Department to send us advanced stroke patients. And we work with our other marketing people for our neuroscience program overall. And many of our stroke members, especially our nurses, attended the Pacific Stroke Association conference this year. Next slide. And then our goals for next year is to continue to do rapid TPA administration, give more thrombectomies as indicated, improve our door-to-device time, like I mentioned, in terms of our neurocath lab procedures. And then if we qualify, moving towards a higher level of Joint Commission certification, such as thrombectomy capable, marketing the rest of our neuroscience program together with our stroke program, and potentially in the future become an officially comprehensive stroke center certified, although we already do all those procedures that other comprehensive stroke centers do. So I think that's the last slide. Go on to the next one, and I'd be happy to answer any questions.
Wow, you're a very busy guy there, Dr.
Yes, we are.
Well done. Thank you. Any questions for Dr. Rose? Thank you very much. Very informative.
Thank you.
Thank you very much.
Okay, thank you very much.
Program.
I know. There's been a lot of work.
Makes you wish for sure.
All right, I'm going to then now turn it over to Ajay CL, our Senior Vice President and CFO to give the financial presentation for May.
Hello. We'll start with the operating indicators. They're pretty much all green for the month of May. Inpatient census was 16.1 over budget. ABC for all the services, 8.6 over discharges, 74 over patient days, 500 more than budget. Although observation equivalent days are down, I take that as a positive because that's they're getting to the right spot, and the ALOS is better than budgeted. Moving on to the next page. Similar story, case mix index, a little better than budget. Deliveries, great story, and you'll see this continue on for the next few months. As Terry tells us, surgical cases were better than budget. Cath lab was a little below, and I'll get into more details on both of those in the next slide. Outpatient visits were pretty close to budget, 279 below. And ED visits were about 314. On the surgical and cath lab indicators that we mentioned earlier were higher by 11. There were two areas that were down, which was vascular and other surgical cases. And on the cath lab, we were 13 below budget. And most of the areas, peripheral vascular, cardiac, and non-vascular IR, all a little behind budget. Moving on to our FTEs for May, our productive FTEs were about 15 FTEs below budget, and the non-productive FTEs were almost at budget. So overall, we're about 15 and a half FTEs below our flexed budget, and our FTEs per adjusted occupied bed are also below budget by 0.15. On the next slide, you'll see the contractual deductions and allowances. You will note that our gross patient revenue was $12.5 million above budget. And if you'll recall, last time I had mentioned that with the new contractual allowance model that we're more critically looking at what is bad debt versus contractual allowances. So there's been a little bit of a shift. You're continuing to see that shift here. Our contractual allowances are higher by about $11 million, and the bad debt was lower by about $1.3 million. Of course, these are all higher because our revenue was revenue. But overall, our deductions were right at budget, etc. On the next page, we have the GASB format of our operating income. So I talked about the first couple of lines there. The next line is the net operating revenue. You can see we were about $2.6 million, 5% better than budget. However, our operating expenses were about $4.1 million higher than budget. The majority of this increase is in our benefits line item. Has been the same thing that we've been talking about the last couple of months. Unfavorable $1.8 million due to higher pension and OPEB costs, and salaries were higher $1.2 million, and that's primarily due to the rate that we're ending up paying is a little higher. Although on the efficiency piece, you saw we're flexing well, we're doing all of that, the rate is higher, so that's what's causing. So between those, that's the biggest pieces of our of where we exceeded budget. So our net operating income was actually a loss of about $1 million versus we had a a positive budget of 444, so you're off by about 1.5 million. When we bring in the non-operating income, that was also a little below plan, primarily because of the unrealized gain loss on investments. I mean, if you look at your own portfolios and if you are sort of nicely weighted between equities and debt, May was a great month. But in our case here, we're mostly in debt, and debt didn't do as well. So we lost some money there. And as a result, we had a net income loss of actually 519,000 versus a budgeted gain of 1.5 million. On a year-to-date basis, we're still better than budget. We're at 20.3 million, 3.5% versus budget of 16.3, 2.9%. I won't spend a whole lot of time on the FASB. Just moving on to the last page, the GASB EBITDA. I just wanted to share the EBITDA with you, which is in the middle of that page, of the page. The margin right above that, we had a margin of 2.6 million versus a budgeted margin of 3.9, 4.8% versus 7.5. And on a year-to-date basis, we've also fallen a little behind budget. Budget was 42.4 million, 7.5%. We're at 35.5, 6.1%. So I think overall we're doing a good job on flexing. We're doing, I think some of our estimates around pension and OPEB and those kinds of things have worked out before.
Any questions for Ajay? All right, I am going to present the operations report for June. I do just want to mention a couple things. They are very preliminary. We had the end of the month last week, and we had holidays, so we're still and it's the end of the fiscal year, so we're still working on pulling some of everything together. You'll also see in our surgical and cath lab, we had some budgeting anomalies that I will also talk about too. So let's start with outpatient observation days. As you can see in June, days came in at 197. It's very same as May, which was 186 days or 48.6%, favorable to the budget of 383. And continue to work to ensure that we get our patients in the appropriate levels of care. Moving on to total gross revenue, patient gross revenue came in at 220.7 million for June, which was consistent basically with a budget of 221.9 million by 1.2 million or 0.5%, and favorable compared to June of 2024 by 31.7 million or 16.7%. You'll see that June's performance is mainly driven by higher outpatient gross revenue, offset by lower inpatient gross revenue, and that's a little bit different than what we've seen in the past. And we're also, again, assessing for any late charges for June. That is ongoing right now with that. Moving on to trauma cases, they came in at 163 for June, which is favorable to the budget of 115 by 48 or 41.7%. And year-to-date, favorable cases were favorable to the budget by 532 or 39.9%. Inpatient trauma cases of 40 for June were unfavorable to the budget of 74 by 45.9%, and outpatient cases of 123 for June were favorable to the budget of 41 by 82. So again, you'll see we'll be budgeting now that we've got 1 year behind us in terms of much more on the outpatient side than the inpatient. Looking at our activation, trauma cases by activation code, as Jen did explain to us, we had a total of 163 cases with the following breakdown: 13 alpha, that's the highest level or the most acute patients, followed by 48 bravo, 102 delta cases. In June, out of the 163 trauma activated cases, we had 53 falls, 40 motor vehicle crashes, 4 medical symptoms, 10 body injuries, and then 47 other with no thanks at this point. Looking at our gross revenue for trauma, it came in at $16.9 million for June, which was favorable to the budget of $16.2 by $0.7 million or 4.4%. Inpatient trauma gross revenue of $10.4 million for June was unfavorable to the budget of $14.5 million by $4.1 million or 28% due to the lower cases. Outpatient trauma gross revenue of $6.5 million for June was favorable to the budget of $1.7 by $4.8 million, again, due to the higher cases in outpatient. Looking at our inpatient gross revenue of $132.6 million was unfavorable to the budget by $2.2 million, but $23 million or 21% higher than June 2024. The unfavorable performance in June was mainly driven by our surgical services, along with room and board and some ancillary services. Looking at our outpatient gross revenue, it came in at $88.2 million, which was favorable to the budget by $1 million or 1.2%, and 10.9% favorable to June of 2024. Favorable performance in June was mainly driven by our ancillary services, specifically CT scanner and our emergency department. Looking at our inpatient average length of stay, for the month of June came in at 5.18 and was unfavorable to the budget, which was at 4.92 by 5.1%. That was consistent with June of 2024 by 0.3 and very consistent where we've been the last couple of months. I do want to mention that we did have 15 patients with stays over 30 days that were discharged in June. We also had one patient who had a stay of 150 days that was also discharged in June. So as you know, all those days hit. So if you exclude this one patient, the length of stay would have been 5.05. This was a very complex medical patient with CHF, coronary artery disease, GI issues. So this was a very complex case. Moving on to discharges, looking at June, we came in at 1,102, which was consistent with the budget of 1,108 by 6. Year to date, discharges were consistent with the budget by 118 or 1%. Looking at our patient days of 5,317 were unfavorable to the budget of 5,446 by 129 days or 2.4%, but were 2% higher than the fiscal year 25 average, and 19.8% favorable to June. I do just want to mention, because we did in certain areas like IMC and telemetry, our days were down, but I think, as you know, we're doing the construction in Morris Hyman. We did move our IMC unit up to the 3rd floor. We did reduce from 18 beds down to about 12 less beds, and we also took some of the telemetry beds and med-onc beds. So some of that is, we're taking care of the patients, but looking at sort of where they're going and getting them to that appropriate level. Inpatient average daily census came in at 177.2, which is unfavorable to the budget of 181.5 by 4.3 or 2.4%, mainly driven by the lower patient days. All right, looking at our surgical trend, total surgeries in June of 499 were unfavorable to the budget of 613 by 114 or 18.6. It's this, the number of surgeries budgeted, really we have a budget issue here in terms of, the 613 is the highest number of surgeries that's ever been budgeted. I think as Ajay looked into it more, and I did just in terms of that it was budgeted incorrectly at this point. You'll see that in the surgical trend and also in the cath lab. So those were two areas. And what I'm going to show you basically is a 3-year. We're still under budget for the month if you look at sort of our trend at 499. but not to the level that was budgeted in that. Our inpatient surgeries of 232 were unfavorable, and outpatient surgeries were also unfavorable. But we did do 7 TAVR cases in June. So if you go on to the next slide, you can see what we are really comparing to. We took the last 3-month average, and we are still lower. As you can see, the last 3-month average is about 531. And the 3 areas that really are the main areas are the general surgery, vascular, and neurosurgery. We did in neurosurgery very specifically in terms of being down that, on average, those 16 cases. We did have one of our neurosurgeons off for 2 weeks, and we had another that was off for another week. So we did have a lot of time off in terms of for neurosurgery. So that's one of the main things. Moving on to cath lab, you can also see the cath lab volume is unfavorable to budget, but again, was budgeted very high. And so as you move on to the next slide, you can see we took, again, the last 3 months average, and we still were unfavorable, but looking at the main 2 areas were interventional radiology and vascular. If you're looking at the last 3 months average in terms of it. So both of those areas were down, but not overall really to the extent as you compare that to the budget. All right, moving on to deliveries. We had another busy month in deliveries. We came in for June at 147, which was favorable to the budget by 10 or 7.3%, and 53.1% favorable to June of 2024. Year-to-date deliveries were favorable to the budget by 8.3%. Also, C-section rate came in at 28% of total deliveries. I'm also told, and we're looking, July is also another busy month for deliveries. Moving on.
Is that because of St. Louis?
That's some of it. In terms of it, yes. We are seeing more deliveries from since they've closed. But I think there's other factors that I know they're working on. Looking at the non-emergency department outpatient visits, they came in at 9,076. They were favorable to the budget by 170 or 1.9%, and favorable to June of 2024 by 11.5%. The favorable performance is really driven in 3 areas. Cardiac rehab was 32% over budget, infusion center 13.8%, and outpatient wound 11.8%. So those are the areas driving that. Looking at our emergency visit trends, we were below, came in unfavorable to the budget. We were at 5,075 compared to the budget of 5,269, so about 3.3%, but favorable to June of 2024 by 2.4%. Really what we've been continuing to see are less complex cases and more complex cases coming through our emergency room. Now, as things may change, given some of the changes we may see over time with what's happening with the Medi-Cal program at the state and federal level, but we're going to continue to watch that. All right, moving on to our gross revenue cap for June. As you can see, surgical services revenue was unfavorable to the budget by $4.1 million or 10%, mainly due to the areas that I talked about in terms of it, and also in terms of the budgeting. Cath lab revenue was up $1.7 million or $1.8 million. Despite the fewer cases, we did have some of it was timing. We did have some revenue from May that we realized in June. And we also had higher revenue from the mitral clips, Watchman, and some of the pacemakers that were put in in June. The other area that was down was room and board. It was down $2.8 million or 2.9 or 6.4%, really driven by patient days. Other areas, birthing center, emergency departments, and ancillary were all above budget. Looking at our preliminary payer mix, as you can see, in terms of government payers, we did come in favorable to the budget at overall at 72.1% compared to 74.6%. HMO was also favorable to the budget at 4.2% versus 1.7%. PPO was just pretty consistent with the budget coming in at 20.4% versus 20.8%. And you can still, it was a little bit higher, and it was TRICARE. Be consistent, those three areas with the budget.
Do we have any idea about the new federal budget and how that's gonna?
Yeah, there's a lot of discussion about that. I know I've been on some calls with California Hospital Association and district hospitals and more, and all of that is really right now being looked at, and there's still, you know, what we're hearing is that it can impact hospitals anywhere in terms of their Medi-Cal payments, anywhere between 14% and 30%, but that also doesn't take into account some of the other impacts of the work requirements, also having to reaffirm reapply pretty much every 6 months for certain patient populations for Medi-Cal, because a lot of that is just people are going to fall off, and so that's a lot of the worries from that standpoint. So we're still working on that because it's over 1,000 pages and digging with different timelines and all of that. So it is being, we're starting to really, I'm going to work with finance and that team to put together sort of what we see as that impact over the next number of years. It's as you know, a 10-year horizon, but it's definitely going to impact hospitals and us very much.
My concern is Medi-Cal, there'll be non-payment periods.
Right. Yeah. I mean, I think you're going to see these.
Charity care will increase.
I'm sorry? Charity care.
And charity care.
Yeah, the self-pay is going to, before Obamacare went into, we saw a lot more, being uninsured. And so that's what, in terms of where you're going to see more. You also may see more people utilizing the emergency room. So there's a lot of potential impacts that we can see throughout the whole health system. If they're not getting care, yes, there's also in terms of making sure patients feel comfortable coming in and getting the care they need. That too.
Even the exchanges are going to be impacted.
Yeah, there's other things too with the exchanges where a number of individuals go to get their health insurance now, not just Medi-Cal, but other insurances.
But there was something in the bill for rural hospitals, and I know sometimes we qualify as a rural hospital.
Yeah, there is a little bit in there.
I think they've defined it very narrowly. We'll certainly look at that.
Yeah, there's all those things that now everyone's sort of peeling the onion apart, and we'll be putting together really sort of some projections around how we're gonna impact us. But the healthcare industry as a whole and hospitals especially, there's going to be some challenging times ahead.
They're peeling the onion, and there are a lot of tears.
Absolutely. Yes. Their environment is going to be more challenging than it is. And I think the feeling is it's going to get worse or it start to see things improve.
Hard to imagine how it won't get worse.
It will. Yeah. It will. And that's what we have to look at our community. We have to look at what the impact's going to be. We have to look at all the different things that we are going to have to do to ensure that that our community gets the care they need. Mm-hmm. And we stay financially solvent.
And they haven't taken away any of those unfunded mandates like seismic or any of those.
No. All of those things are still in place, so it's all that juggling act. Good question, but I will be talking more about it as we continue to look at it. All right. Looking at our productive FTEs, they were favorable to flex by 35.9 or 2.4% at 1,487 FTEs. Non-productive FTEs for June were also favorable to the budget by 2.5 or 1.1% at 229. Our total FTEs for June were favorable to our flex budget by 2.2%, 38.4. They came in at 1,716.1 FTEs. In terms of our total FTEs per adjusted occupied bed, we came in at 5.81, which was favorable to the budget of 6.06. All right, moving on to our radiation oncology treatments. As you can see, that we did in June, treatments came in at 235. I do want to just talk a little bit more about this because I know we've been having some discussions. We really are seeing, especially in our breast patients, seeing them get more, high intensity fractionated care. So we're seeing, they don't have to come in as often now for treatments. And so, but those are sort of the hyper fractions where they can really pinpoint the cancer and do that. So we're seeing more complex cases, but overall we are seeing them, patients need less treatments, which overall is better for our patients. We are seeing more IMRTs, so again, and more of the complex types of cases. In terms of our consults, in June, we had 36 new referrals, and we also saw 22 patients in our clinic, and we had our conversion rate of 25%, so sort of in line what we've been seeing in the past. Moving on to the Washington Health Medical Group, we did have visits that were unfavorable to the budget by about 12.3%. I know we just spoke with the group, and they are still running the reports in terms of it. So I think this variance, because they're still closing charts, and so I think that once we get everything complete, that we'll have more of a 6 or 7% variance versus the 12.3% unfavorable. We did have 2 of our high producers that took time off. And we also had one of our physicians on medical leave. But again, we are still closing the charts and getting the numbers on the. Looking at the Development Corporation, the outpatient visits came in at 2,379. They were favorable to budget by 131 or 5.8% for June, and favorable to the prior year by 36.2%. Our rehab center visits were favorable to the budget by 8.8%. Our Washington Outpatient Surgery Center cases were favorable to the budget by 3.9%. Our Peninsula Surgery cases were unfavorable to the budget by 31 cases or 27.9%. That was primarily driven by less pain management cases, and then also our new physician, Dr. McDonald, is just ramping up over there too. So those are the 2 areas. Looking at our key financial statistics, we came in at 125 days in terms of days cash on hand. It is down by 2. We had a number of expenses as we ended the year over this last month. And then charity care came in at 197,000, a little bit less than the previous. And lastly, in terms of our, for the year unhoused patients, we had total unreimbursed costs for the period of July to June, or 12 months, was at $7.1 million. The cost of unhoused care includes food, clothing, pharmaceuticals, DME, transportation, and other needed services. For the 12 months, there were 2,245 patient encounters, representing about 972 unique patients. That's that, and I think that's it. Any questions? All right, let's move on to Employee of the Month. And this is for July, for new fiscal year. Very excited to announce that Jill Webb, our financial analyst, is Employee of the Month. In 1995, Jill made the decision that she would have a far greater impact than she made 2 decisions that would have a far greater impact than she could ever imagine. She joined the staff of Washington Health as a support analyst, and 2 months later, she married the love of her life. As her career grew at our health system, so did Jill's family. She became the manager of the financial planning and analysis team and had 2 children born here at the hospital. In 2001, she transitioned to the role of finance manager, later becoming a per diem financial analyst the following year. and in 2016, she transitioned back to her full-time analyst role. Everyone who works with Jill says she provides exceptional feedback and always willing to help out. She's keen on details, thorough in her analysis, and goes above and beyond to provide best-in-class service to all constituents. She understands the hospital services, growth of strategic service lines, finance-related databases, and all the important details of each and every Washington Health managed care contract. She has a strong work ethic and commitment to Washington Health mission, vision, and values. In addition to her technical skills and willingness to understand the finance planning, analytical, and modeling needs for many partners throughout the system, she's earned the trust of her peers, colleagues, and senior leadership. Congratulations to Jill, our Employee of the Month, as she celebrates 30 years of marriage and 30 years with Washington Health. All right, I'll move on with the calendar for the month of June. All right, I do just want to say that on June 12th, we were recognized, Stop Waste recognized Washington with an Environmental Leadership Award for rescuing over 13,000 pounds of unused food since July of 2023. So we'll have a picture of that. Also, you know, I know Jen Kubitz talked a lot about being out in the community, and you can see that through the month of June. We also had Dr. Agarwal present on the Structural Heart Program, and also participated in the Fremont Pride Fair on June 21st. Dr. Achanta on June 25th talked about the future of surgery, robotic advances with the Da Vinci system, had over 368 views. Again, we've heard a lot about our stroke team. They were out in the community doing blood pressure checks and stroke education on June 26th. You'll see we've been busy at the Fremont Concert Series, and both on June 26th and July 3rd. I know this last weekend we were at the Alameda County Fair and Livestock Auction, and I know that we will be having a presentation on that, but really supported many of the young children and who are 4-H, and we purchased a number of hogs and steer and lambs that ultimately our patients and our staff and others in the cafeteria will be able to enjoy. Also want to say that we were recognized on July 8th with a Safe Kids Day proclamation, so you'll see that too. All right, you can see some of the pictures. Thank you to our board members for participating in the concert series.
Wow, look at that.
Corona.
And wearing the jacket.
What?
And wearing the jacket.
And wearing the jacket, yes. Then coming up in July, we've got the concert series and focusing, we'll be highlighting opioid safety and stroke education. We'll also be participating at the Niles Dog Show, and again, our trauma team is out there providing education. On to the next page, you can see Dr. Eric McDonald, one of our orthopedic surgeons, will be talking about anterior total hip arthroplasty on Facebook and YouTube on July 23rd. Again, in terms of highlighting at the concert series, the trauma team will be talking about bike helmet safety, which is always important, and also diabetes education. And August 1st, we will be participating in the Traversio Vasquez Health Center's Women, Infants, and Children fair that we'll be at. Then you can see the other fairs that we will be at. Also just want to highlight August 11th. back to school again for this area, and so we will be participating and doing the Welcome Teacher Day again in the 2500 parking lot, where kids can come through and get a flower. And Heart and Health for South Asians, we will be doing a presentation on Facebook, and our NP nurse practitioner, Megana Bachu. We just want to remind everybody the 39th Annual Top Hat Gala is on Saturday, October 11th. So we'll be sharing soon the theme, but mark your calendars for that. And that is what I have for calendar.
Thank you. Any questions for Kimberly? All right, then let's move on to the action item.
We have one action item this evening. It's the consideration of the project bids for, very excited, urgent care moving forward, and also a revised budget. So we completed the planning for the urgent care clinic. We went out to bid. We received 4 bids. And we are recommending moving forward with the lowest bid, that is J.R. Griffin's bid at $1,556,516. That's the lowest bid. At the time that we did the budget, it was about a year ago, and the lowest bid did come in over budget, over about $237,000. But as we know, we've seen significant increases in costs in building materials. We've also added some additional furniture and fixture, given that we've got the floor plan finalized, and also additional signage is needed. So we are recommending, in terms of moving forward with the lowest bidder, in addition, increasing the not-to-exceed budget to $2,520,129. And we are continue to be on target for the opening in middle of November.
Wow.
Yeah.
So.
Well, then let's consider this action item.
Excellent.
Director Stewart.
Mr. President, I move that the Board of Directors award the bid to the low bidder, J.R. Griffin Incorporated, and enter into the necessary agreements for the construction of the urgent care clinic, and approve an additional $320,624 to the project budget. This will increase the not-to-exceed amount from $2,199,505 to $520,129. I'm not used to those kinds of
I'm going to choke on those numbers.
Thank you. Thank you. Cheryl.
Ready? Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Ethan?
Aye.
That motion passes. Any other announcements?
Nope, that's it.
Okay, well, then this meeting is adjourned.
All right. Thank you.